Good morning, everyone. This presentation will share sustainability efforts within our state pediatric facility recognition program. Next slide, please. To provide some background, Illinois is the sixth most populous state with a population of 12.7 million. If you could proceed to the next slide, that would be great. And then our population also includes a correspondingly large pediatric population. With respect to hospital infrastructure, our state has over 200 hospitals. Some are specialty hospitals. 184 have emergency departments, and 108 of those participate in our pediatric facility recognition program. We implemented pediatric facility recognition over 20 years ago in 1998, and it began as a completely voluntary process. But we structured it as a three-tiered system to ensure that it would be inclusive and allow all hospitals to potentially participate at one of the three levels. And then several years later, participation became mandatory for the 60+ EMS resource hospitals in our state. These are the lead hospitals for pre-hospital care, and most of those hospitals were already participating. But this mandate was then adopted into state regulations. And currently, we're working with the State Trauma Legislative Committee to incorporate a requirement for all trauma centers to participate in pediatric facility recognition. The Trauma Committee is very supportive and will continue to work with them on this regulation. As previously mentioned, ours is a three-tiered system with the first two levels, SEDP and EDAP, focused on the emergency department. And then because the tertiary care centers are such a key entity in this overall process, we created a third tier, the PCCC level, that goes beyond the doors of the emergency department and sets criteria for those hospitals that receive pediatric transfers and admissions. This allowed us to define requirements for that level hospital as well. And you can see on this slide the number of hospitals designated at each level. Next slide, please. This slide provides a snapshot descriptor of each level. The standby emergency department for pediatrics, or SEDP level, is typically a smaller hospital, many of which are critical access hospitals. Their emergency departments are at the standby or basic level, and they may not have 24-hour physician coverage in their emergency department, but they do have advanced practice provider coverage in those circumstances. They also typically don't have inpatient pediatric capabilities. The requirements for this level are basically to ensure that they have the capabilities and resources in place to recognize the unstable child, initiate appropriate resuscitation measures as needed, and then transfer to a higher level of care or for specialized care as needed. The emergency department approved for pediatrics, or EDAP level, is typically consistent with a hospital that has a comprehensive emergency department. They are required to have 24-hour physician coverage, and they're able to provide more pediatric services, but they may not have a pediatric inpatient unit. So they may also need to transfer, and so they need to have transfer agreements in place to route those kids to a higher level or specialized level of care. And then the top level in our system is the Pediatric Critical Care Center, or PCCC. And these are the hospitals that provide pediatric intensive care. They have pediatric specialty services. Their emergency department needs to meet all of the EDAP requirements. They also have to have a dedicated PICU and a number of pediatric specialty and inpatient services and resources, including a transport team or an affiliation with a transport system. They develop transfer agreements with the EDAP and SEDP hospitals, and really importantly, they are required to provide feedback and quality improvement information back to the hospitals that transfer pediatric patients to them. Next slide, please. Now, one of our sustainability measures has been using our existing state geographic infrastructure. Next slide, please. And the graphic on this slide displays our state divided into 11 colorized regions. And this regional structure is historically how oversight to EMS and trauma services is provided. If I could have the next slide, please, that would be great. Our EMSC program adopted this same structure with our facility recognition program, which has been beneficial. So to provide some geographic perspective, Region 11, which is located in the upper right corner, that's actually the city of Chicago. Because of its dense population, it's its own region. And then the regions that immediately border Chicago, those regions are primarily urban and suburban. And then as you fan out to the other larger regions throughout the rest of the state, those regions are primarily rural with some urban pockets. When we initially began crafting the facility recognition program, we knew it would be challenging to roll it out all at once to all hospitals statewide due to the large volume of hospitals. So we leveraged this regional approach. We secured a well-known and well-respected advocate in each region who supported facility recognition. And then we rolled out the process region by region over a few years. Those advocates in each region stood side by side with us as the state as the educational rollout sessions were conducted in each region. And so from the beginning, we really strived for both a top-down as well as a bottom-up support system as we implemented the process. Then as the hospitals in each region completed the initial application and survey process, we conducted regional recognition ceremonies and had the director of the Illinois Department of Public Health, as well as representatives from our state hospital association be on hand to congratulate and formally recognize each hospital. Also, as we were beginning this process, we knew that we would eventually need to do return visits to the hospitals over time to ensure continued compliance with the requirements. So the regional approach is really helpful in that it allows us to focus each year on specific geographic areas that are undergoing their renewal cycle. And lastly, one of the requirements within our facility recognition program is that each of the 11 regions has to have a regional pediatric quality improvement committee that meets quarterly. So each recognized hospital within each region needs to participate in their regional committee, and the committees work on regional QI projects, they network with each other, they share resources. And so these committees are another example of a bottom-up approach, and they've been very helpful in sustaining facility recognition at the local level. An added benefit is that as regions go through the renewal process, they use their regional committee meeting structure to discuss the renewal process and to help mentor each other. Next slide, please. Our survey process is another avenue in sustaining facility recognition because it allows us to get our foot in the door of recognized hospitals and assess their continued compliance with the requirements, and also to provide some guidance and education during the survey. So the renewal surveys keep facility recognition on their radar. Although hospitals may sometimes think they're being compliant with the requirements, their self-assessment can vary sometimes from the survey team findings during an in-person inspection, when we actually review their educational files, review their quality improvement, their policies, and then go into their supply rooms as well as unoccupied patient exam rooms to look for each of the required equipment and supplies. So the survey process really helps to validate compliance, provide guidance, and also gives us an opportunity to reinforce on a face-to-face basis the importance of pediatric readiness and pediatric facility recognition to hospital personnel and hospital administration. We conduct the renewal surveys every 4 years. So each year we conduct renewal surveys in 2 to 3 regions so that by the end of 4 years, we've completed surveys in all 11 regions, and then we begin the process all over again. We're currently in our 5th cycle of surveys. Beginning last year, we developed a virtual survey process with COVID, and that allowed us to continue our surveys during the pandemic. Kelley Jones, our EMSC coordinator, has a poster Q&A this afternoon regarding our virtual survey process, if anyone is interested in that information. Our survey teams consist of physician and nurse experts. And then in addition, we have a pediatric disaster preparedness coordinator who's part of the survey team. And she assesses the inclusion of pediatric needs into hospital disaster planning. The survey teams also include me and Kelley, who's the EMSC coordinator. And then we serve as the state health department representatives. Surveyors receive a $200 a day honorarium. They also receive travel reimbursement, and that's supported through grant funding. And there are a number of documents that have been developed and revised over time to assist with the process. These documents include guidelines, educational materials, application packets, surveyor checklists, as well as correspondence from the state health department to the hospitals, both before and after their surveys. And having these types of documents serves to ensure a consistent and standardized approach to the overall process. Also, because the designation of hospitals is through our state health department, it's important for us to maintain hospital files for a period of time in case there is a need for retrieval of documents or for any issues in the future. So we have a file retention and archive process in place. We maintain 2 cycles of documents from hospitals, which is 8 years of files, and then any documents older than that are destroyed.
Evelyn?
Next slide, please. Yes.
I have a quick, so there are a couple of questions in chat. Do you want to wait until the end, or do we want to bring them up as we go? I apologize, I didn't ask you before.
It's up to you. If you think that there's time, I could look at those here now.
So Corolla is asking how you fund the survey process, and how well did the virtual surveys work for your recognition program?
Yeah, so we do use some funding from our partnership grant, as well as we have an HPP funding because we're doing disaster preparedness assessment. So we use some of that funding to support the surveyors' honorarium and travel. And then in terms of the virtual process, it's obviously not the same as doing the in-person, but it actually went pretty well. There was just a lot of additional documents that had to get submitted prior to the survey. And we had them do a virtual hospital tour and actually provide us with equipment checklists and things so that we could verify those kinds of pieces that we actually like to be right there and visualize. But overall, it went pretty well.
One more question that I expect won't take very long. So Patricia Frost asked, does the hospital apply for facility recognition, or is it a state requirement?
The hospitals do apply for recognition, but there are certain hospitals in which it's a mandate, those EMS resource hospitals, which includes 62 hospitals within our state. And even though it's not a requirement, our trauma centers do participate, but we are working to ensure that that's a mandate for those hospitals as well. It's voluntary for all other hospitals.
Great, thank you.
Sure. So moving on, because the designation of hospitals is through our health department, we talked about the file system that we have in place. And so moving on to this slide now, other sustainability efforts include key entities and infrastructure. So the lead agency responsible for facility recognition is our state health department. They formally license hospitals. In addition, they are the entity that designates trauma centers, perinatal centers, stroke and STEMI centers, and others. So they have not only the history, but also the authority that lends to their being the designating body. In addition, the state health department supports my position as the EMSC manager, as well as Kelley, who is our EMSC coordinator. So having 2 positions allocated for EMSC definitely helps us to sustain and continue the various activities that are associated with facility recognition. But understand that this did not happen overnight. Our facility recognition program began over 20 years ago, and a full-time EMSC coordinator position was just approved a little under 3 years ago. Our state EMSC advisory board has been in place since 1995, and it includes representatives from key professional organizations all of whom are strong advocates for facility recognition. And in addition, the advisory board has several committees that report to the board, one of which is our state facility recognition and QI committee. This committee was initially convened back when we were developing our facility recognition program, and they've continued to meet every other month since then. It's this committee that makes recommendations for revisions to the requirements outlined in the state regulations. They also develop educational and quality improvement resources, which assist hospitals with some of the requirements. Lastly, I mentioned on a previous slide that each of the 11 regions in our state are required to have a pediatric quality improvement committee. The chairpersons of each of those committees are members of this state committee, and they each report on their regional committee activities to the state group. So we have a direct connection between the state committee and each of the regional committees, and this is another way of institutionalizing the process. Next slide. Also, the facility recognition process and requirements have been adopted into our state regulations, and we've revised these regulations several times over the years. There are specific requirements for each recognition level. We know that rulemaking is a very time-intensive process, but it's really a key step in being able to sustain and institutionalize your facility recognition program. After confirming that hospitals meet all of the requirements, they receive a congratulatory letter and a certificate of recognition that's signed by the director of the Illinois Department of Public Health, as well as the division chief of EMS for our state. We see these frame certificates in hospitals when we go out to visit them for their renewal surveys. And we also make sure that hospitals are publicly recognized for taking the steps to achieve these levels of recognition. A list of recognized hospitals is on our Department of Health website, also on our state EMSC website, and our state also has a hospital report card and consumer guide to health, and the hospital pediatric recognition levels are updated regularly on that website. These are ways to just help ensure public awareness and to recognize hospitals for taking the steps to be prepared to meet the needs of children. Next slide, please. We've also been very fortunate to receive other sources of funding that have supported our efforts. So hospital preparedness program funding supports a dedicated disaster preparedness role who serves on our survey team and develops disaster resources for the hospitals. Also in the past, we've received targeted issue grants and also funding from our state Department of Transportation that has assisted with data and quality improvement initiatives. We also have a strong academic partner with Lurie Children's Hospital, and they provide that clinical and academic expertise that's really integral to the growth of our program. And the support of a number of other key organizations within our state, including our state hospital association and our state critical access hospital association, has also been beneficial to our efforts. Next slide. Other considerations, that slide, thanks. Other considerations regarding sustainability is to initiate discussion with other designation programs within your state, such as your state trauma or perinatal program, and ask to see what kind of sustainability measures they have in place that you might be able to leverage. It's also important to explore ways that you can provide incentives and resources to your hospitals to continue their participation. Otherwise, some may find it too challenging. Our committees develop education, quality improvement resources, as well as tools and guidelines that the hospitals find helpful. We also try to share new evidence and research that supports PEDS Ready and facility recognition and get that out to the hospitals. And information from this grantee meeting will be shared as well. Our EMSC coordinator shares information with the hospitals, and she also conducts an orientation for new pediatric quality coordinators to help guide them in their role and share resources with them. So explore opportunities that hospitals may find helpful. I'm really impressed with all the great work that's being done in states and all the examples and other state experiences to draw upon. Just remember that facility recognition is a huge endeavor. So just take it one step at a time. Be patient, persevere, and you'll definitely get there. Next slide. I just want to thank you all for listening and thank you for all that you do.
Evelyn, there's one more question. Patricia Frost is asked, are you considering to expand the EMSC facility recognition program to recognize EMSC systems of care like STEMI or stroke?
We do within our state have a STEMI and stroke program. We have not looked at how we might be able to integrate pediatric components within that process, but that's certainly something that we will look upon as an opportunity in the future. Thanks, that's a great idea.
Thank you. Go ahead and turn the time over to Brandon with the Wyoming EMSC program.
Hello, can everybody hear me okay? I hope so.
Yeah, sounds good.
All right, cool. Hey, so I'm Brandon Kelley, the Wyoming EMSC coordinator, also the State Office of EMS acting director, or whatever they want to call me. This week, good to virtually see all of you again. Yeah, so my talk here takes a little bit of a different approach. I haven't had a lot of time to get into sustain mode. So this is more of how we did it in this crazy little state we call Wyoming, and then kind of where it is now. So an update from the last time I ever talked to any of you guys about it. So yeah, so to recap this, I guess to start off with transparency is, any of the HRSA folks can absolutely attest that I said from the moment I started doing this is this will never happen in the state of Wyoming. There will never be any buy-in. No hospital is going to jump in unless I pay them to do it. It's never going to happen. Well, I am very pleased to eat some crow and tell you I was wrong. It hurts a little bit inside to say it out loud, but it's also a really good thing. So we built this thing under the model you see in front of you. It had to be easy. It had to actually mean something to the people who participated in it. And I didn't get into trying to define what meaningful means for them, right? I let them do it themselves and determine why they wanted to be interested. I based it on data and best practices, and the best thing that I had was the NPRP and those studies that have happened as a result of it. And so this whole thing was designed with an intention. I don't know if you remember the 2013 scores off the top of your head, but Wyoming could be described as real bad. That's how I've described it in every meeting I've had, is just real bad. So that was my metric, right? I'll know this thing was effective when our scores, even at the individual hospital level, dramatically improved from where they were. So that was my version of meaningful based on best practices, and that's the best science I had access to, so I went for it. The other is that it had to be uniform. So even though we're a small state, I'll get into how small here in a second. As far as hospitals go, everybody had to be on equal playing ground. So there's actually 3 different levels inside of our system, and those 3 levels, in order to get from one to the other, you've got to obtain the one before it. So even Denver Children's would have to get the very base level that our smallest critical access hospitals, that's all they're going to be able to maintain, but they have to go through the process. Okay. So, and then it's scaled to existing and potential infrastructure of the state. What that loosely translates to is we ain't never going to have a Denver Children's in Wyoming. It isn't going to happen. We're not even going to have someone with the capability of ERMAC or, yes, I know, I'm sorry, Kathleen, I see that. Yes, Children's Hospital of Colorado, or Rocky, I forget how you say their name as well. But yeah, the moral of the story is we're not going to have that here. So it's designed that this is going to be meaningful for the people that are here and are functioning in our state, and those that have the capability, particularly those that have the catchment for our pediatric patients, Colorado, Utah, ERMAC, and Billings. They can also be included, but everybody starts off the same. So everybody walks the same road. Next slide. Okay. Nope. There you go. So there was no lofty expectations or demands. In other words, we didn't try to make them turn themselves into a little miniature children's hospital. Okay. We said these are the things that the NPRP and all of I had 2013 data at the time. These are the things that it says you should be reaching for 100% on. So those are the metrics in Wyoming's recognition program, right? You have a physician who's always there that has pediatric training and they maintain it. You have nurses that do the same thing, right? All of those things from that survey are all elements of what pediatric recognition is at that base level in Wyoming. It's not outcome based because at this point we don't have that data, nor do we know. There's a lot of work going on this, but we don't know how to connect those things. At least I don't connect those things together. So this is about building capacity and making sure that you have the baseline was the whole scope of this level. And it had to be meaningful. So I needed carrots to dangle in front of them. And thankfully, the 2013 survey results gave me that carrot because nobody wanted to see their name with the scores that they got in Wyoming. So this conversation became very easy. All I had to do was hold up their 2013 performance results and said, do you agree you have a problem? The answer was always yes. And it's like, all right, here's a way we can fix this. Okay. Next slide. All right, so again, it's based on data and best practices. That what I have is the NPRP, so that's what I went with. And I've already talked about the uniformity. That's why I have a picture of this beautiful facility with, man, what a backdrop that hospital has. But that's the idea. I want all of our big children's hospitals recognized in Wyoming. That's the goal because they are going to get Wyoming's patients, right? So the reason why I crafted it the way that I did is I could have started the opposite way. I could have reached out to the big facilities that receive our kids ultimately, but then it just becomes another version of the big hospitals have to come into Wyoming and help Wyoming do what it already does every day. And I didn't want that. So what I decided to do is start at the lowest tier so that our hospitals can feel this snowball happen, right? They pitch in and they do work. They accomplish the goals that we set out for them. Then in the tier 3, so the big facilities that are out there, the idea is they don't have to meet any expectation of me, right? They are the children's hospital. Who am I to tell them this is what you need to do to fit into Wyoming system, right? What that big system brings in, one of the things they'll be required to do under that tier 3 of our system is they have to bring these small hospitals, these pediatric ready facilities under their umbrella and use their resources and training and staff and telemedicine and all of that to enable those facilities to do better and do better work and produce better outcomes. Wyoming's a very proud state, and each little town that has a little hospital, they're very proud of it. And to go the opposite way, I didn't feel like that was right, and that has paid off doing that method. It would have been a lot easier to start with the big boys, but I got more buy-in and people feel invested by going the opposite way. So it was a good strategy that I didn't know was going to work. All right. So yeah, so our size, we have 25 hospitals in our state. 16 of them are critical access hospitals. The smallest of which has 2 curtain separated beds in their ED and 6 more beds in their hospital proper, and it's attached to a nursing home. All right. To give you an idea of that. And there's several other towns that are very similar to that size on those 16 critical access hospitals. So our highest designation in the state is an ACS2, and that I honestly don't remember because it keeps changing. It's either Cheyenne or Casper. I do not recall which. But anyway, so the barriers, I didn't think anybody would want to play. And to be perfectly honest, I didn't want to play. I thought this was going to be a failed venture that would cost me a lot of time and not have any payoffs. Thankfully, I was wrong. I also ran into barriers with leadership support in my own circle. My own boss The former EMS manager thought this was a dumb idea, and he didn't think that anybody would do it either. He might have been feeding off of my negativity. I don't know, but if you know the man, that's probably not true. He probably had his own. But anyway, I fought through that, and I said, well, then let's don't roll this out statewide. Let's do a pilot, which I'll talk about in a moment. And from the hospital perspective, one of the questions I kept getting was, why? What's the point of this? We don't keep kids here. We send them out every chance we get, which my response to that was, yeah, but should you? Or do you have to? Or is there a better way, right? The next slide. So the first step is I did not have much help. I wrote this manual. And I mean, I had a lot of help. Let me rephrase that. The help I had was that all of the pieces of our recognition program was already written by the people who wrote the NPRP survey. Again, those were the metrics for the pediatric ready facility, or we call it a pediatric receiving facility because it matches our trauma designations. Yeah, so I wrote this manual. Next slide. And then I swallowed my pride because this thing is 30 pages front and back. It's not just all boilerplate. It's 3 different versions of the same thing. One of them, the first section, is in rule language, because the whole plan is once 50% of our hospitals voluntarily get on this, that first section of this manual will be incorporated into the state trauma rules, and it'll become law, that every hospital in Wyoming has to have, every ED in Wyoming has to have a trauma designation. And so once we have 50% of our agencies volunteering, we will put it in trauma rules, and it'll be law that now you have to do it. That conversation will be a lot easier once 50% of the agencies have volunteered. So anyway, I swallowed my pride and I let folks attack this guide. One of the biggest people picking it apart and telling me how I did everything wrong was this wonderful lady you have pictured right here, Dr. Randolph. But she was doing it out of the goodness of her heart because she believed in this thing. She was my champion. I accidentally found her. She came to me and she said, I like what you're saying here, but you're saying it wrong. And so I said, well, then tell me how to say it right. And she did. And we fixed it and we made it palatable for small little facilities. So her facility is in Torrington, which is one of those small ones like I described before. And she said, we're going to do this. We're going to be the first one. And I would love to have your help in the process, but I'm going to do it with or without you, talking to me. And I said, I love you, Bonnie Randolph. And so we did it. So next slide. The other champion was her chief nurse in the hospital, who took this on just with as much vigor as she did. This is a front picture of the Torrington Hospital. Granted, this is kind of a zoomed in view, but you're pretty much seeing the entirety of the hospital in this picture. Next slide. So some of their problems is they're heavy on locums staffing. Because I mean, it's hard to recruit physicians to live there full time. So what they did is they said, all right, easy enough. If you're going to work here as a locums, here's our policy you have to follow. And that includes all of the pediatric training and all of that sort of thing. So they basically rewrote their staffing model and said, if you're going to come to work here, here's the standards you have to meet. They didn't have any internal PALS or ENPC instruction capability. So they had to pay to outsource all of their annual training, which was another barrier for them because it's going to cost a lot of money, right? They lacked an organized pediatric cache of equipment. They had all the stuff on the list. The problem is the stuff was stored all throughout the hospital and nobody knew where the entirety of it was. And they were missing a lot of policies and agreements. They were missing very specific things that are in the NPRP assessment, or the PEDS Ready assessment, and they do it right, but it wasn't written on paper. Okay, so next slide. So they wrote the minimum requirements. Like I said, they wrote a ton of policies, and not only did they do that, but as they did it, they made their version. They're a Banner Health system, so everything is very controlled through corporate how their policies look. But they actually took their policies because Tammy, the RN, her point of view is, look, if I don't have these things written down, you're going to see other hospitals that don't have it written down. So what I'm going to do is I'm going to make our policy, but then I'm going to strip all of the letterhead and anything banner specific out of it and give you a template at the end of this thing that you can hand to the next hospital and say, hey, if you don't have this, here's one you can plug and play. That wasn't my idea. That was hers. So they talked to their staff about the why, and they got buy-in from pretty much everybody in that hospital. And I paid for hosting ENPC and PALS instructor courses at Community Hospital. So now they have 3 staff PALS instructors and 2 staff ENPC instructors. I invested one time in producing classes. Now I don't have to keep investing in them because now they can produce their own. They can grow their own students now. And anyway, like I say, they did a blueprint for me, all of their own idea. Next slide. All right, so boom, they did it. They met all of the barriers. This is a picture of from right to left. You got the CEO on the left. That's Tammy. That's my bald head in the middle. That's Dr. Randolph. And then she is the chief nursing officer, I think, the one on the far left. That's the picture there. These are newspaper clippings. We made a big deal out of it. They hosted a big luncheon and invited the whole community out there. The CEO was there. We all had lunch together. It was beautiful. Next slide. So then my phone started blowing up. At one point, there were 17 hospitals who were waiting for me to be able to get to them to help them do this. After this article fell, it was huge. I thought we were going to have this done in a year. Next slide. And then we hit another tiny little barrier that I think all of you can relate with. You can go to the next slide. So I don't want to talk about that because I've spent the past year and a half of my life talking about all the problems that COVID created. But I think this picture pretty much captures all of it. You can go to the next slide. But we got to the point to where we could do this again. I pay out of EMSC funds a contractor whose sole purpose it is in life is to have these conversations for me. And since we started rolling again, we now have a total of 4 hospitals recognized, which doesn't seem like a lot, right? But I mean, somebody in here is better at math than I am, but 4 divided by 26 is not a terrible number for really only having a year of work in this. Next slide, or next button. The impact, I have talked to these hospitals that were recognized and got their scores as they entered this one. You're going to see the difference that it made. Huge. One hospital went from a score of 35 to a 91. And the reason why they didn't get 100, remember that was the goal. They didn't get 100 because I was using 2013 survey info. Enough stuff changed between the 13 and today's model that I didn't get the full capture of 100%. So, but that's okay. I'm convinced that if all of our hospitals go through this process, we'll be sitting in the top 10 in the country. And it's just a matter of getting them done. So anyway, next. And that's it. This little picture here is kind of the motto that I've been trying to take, is that, you know what, we're going to do this and it's going to be slow, but we're going to try to make it happen. So if you got any questions, now's the time.
There are a couple quick questions. We've only got about 5 minutes left. Let's see. So Patricia asked, said, instead of reinventing policies, have you considered to have the regional pediatric referral hospital just share their policies as templates?
Yes, I've considered that, but I was working with these first hospitals. I was just worried that it would feel, I wanted the buy-in. Like, I don't know how else to explain that. I wanted, our hospitals tend to, especially when it comes to peds, they tend to feel like they don't have the competency or equipment or skill set to do it, right? And I knew if they could get through this themselves without getting outside help like they always do, not that that's not the right way or there's anything wrong with it, but my goal here was to get commitment and buy-in from those small facilities, right? And that was the way I wanted to achieve it. It may not have been right, but it was the way I chose, and it was effective because all 4 of those hospitals own it. That is theirs. That plaque that's hanging on their wall, they polish it. This isn't polished by the cleaning staff, right? This is polished by the nurses that earned it. And I don't know that I would have got that buy-in if I had went the easy way. Does that make sense? I wanted them to work, and they wanted to work.
Cool. There are a few more questions. We'll see if we have some time at the end to cover those. But I want to turn the time over to Candace and give her just a couple of minutes so that she has a chance.
Yeah, turn it over to her now. I'll go through these chats and I'll answer the questions in text.
Perfect. Thanks,
Okay.
Brandon.
Good morning, everybody. I know we only have a few minutes, so I'm going to give kind of a brief overview of our program. So the West Virginia Always Ready for Kids program, what we call ARC, was started to develop in 2009 when West Virginia first got their EMSC state partnership grant. They formed a committee immediately after that and did a rollout to, I think at the time we had around 50 hospitals, and that was in 2011. And they did get quite a bit interest regarding the program and did some of their first successful visits in July of 2007 or 2011. I'm sorry. You can proceed to the next slide, please. Our application was developed using evidence-based practices and some, of course, information from the NPRP, which I'll be really excited when we get that information back to compare previous scores with scores from this recent survey. It was hospital-based. It really gave us an opportunity to identify system evaluation and system improvement. If you could proceed to the next slide, please. So I took over a long-serving EMSC program manager, Vicki Hildreth. She was the manager from 2009 until 2019. So it was really difficult to kind of jump on and get the grasp of that program and really hit the ground running. I was really excited that she was able to introduce me to a lot of people that were on the committee that were still really invested in the program. And so that really kind of helped. And then, of course, kind of learning about that and then trying to sustain it through the pandemic has definitely been a challenge. But we used this year with the NPRP to kind of plug in the ARC program a little bit. And I feel like that helped with our response. Next slide, please. So the NPRP just kind of gave us an opportunity to open up conversations with the hospitals and help understand what some of their challenges were and how we could support them better. So one of the things that happened during COVID is my program was actually switched to be under our trauma designation program. And so now I have the opportunity to work a little bit closer with the trauma designation and coordination. And I had the opportunity to go to some of their hospital visits before COVID hit. And it really helped kind of start another conversation about ARC again and how closely it's related to some of our trauma requirements. If you could go to the next slide, please. So one of the things, so that's one thing that we do to try to keep ARC a part of the conversation. Another one is our EMSC medical director is a part of our ARC committee, and the hospital that he currently works at is also ARC designated and recognized. And so every EMSC advisory council meeting we have, he always ensures to kind of plug in ARC and talk about it a little bit. And it's really kind of running its course with our trauma designation program. And it's really interesting to see the differences between an urban and a rural hospital or a smaller, larger hospital. So our ARC committee consists of pediatricians, paramedics, RNs, EMTs, and some of our West Virginia Office of Emergency Medical Services staff. So we do meet on a yearly basis and we update our policies and procedures, and then we update our application. And so like some other people were saying, our application or manual rather is also very long. It's about 65 pages. You can proceed to the next slide. So we have also partnered with our West Virginia Hospital Preparedness Program, which is through the Hospital Association. And we try to bring feedback from hospitals at their regional hospital association meetings. And some of that we've gotten is some of their biggest challenges is just the requirements for policies, procedures, and guidelines. And so we did get a group of nurses together to kind of draft up some templates. The HPP program was able to help us contract that. And then some of our EMSC state partnership dollars go towards like the visits for ARC. So we're currently hoping to get this out by hopefully next year. Everybody kind of gets pulled in different directions with COVID and then their full-time jobs and then working with the advisory council. So everybody has a lot going on. But we really think this will ease the burden and encourage participation in the program. Can proceed to the next slide. So some of the things that we have learned and we are trying to keep doing is just remembering to keep ARC and pediatric readiness in the conversation. We're trying to develop materials to kind of tag on with other meetings, trainings, and conferences that are already happening. My thought is kind of if everybody's already in one place for one conference or meeting, why not plug in something else that we're working with? So we have a trauma conference coming up in October, which I think at this point is going to be virtual, but we're really excited that we're going to have about 20 minutes with our EMSC medical director, who's also on the committee of this conference, do a presentation about ARC. So we're really excited to have that cross-pollination of these programs working together. So that's kind of just a brief overview. If you have any questions, I'm happy to answer them. I know we're pretty much out of time here, but I can throw my email in the chat if anybody has anything specific that they wanted to ask, or if they just want to see our application or anything like that. And thank you so much for your time. And I really appreciate the invitation to share with everybody today.